Good afternoon, everyone. Today we'll be discussing about the care of preterm baby. Recently, we have celebrated World Prematurity Day. Good morning, everyone. Today we'll be discussing about the care of preterm babies. Recently, we have celebrated World Prematurity Day, and it's indeed very important to know certain basic aspects of care of a preterm baby. In the next 20 to 30 minutes, we'll know about the classification of preterm birth, the various complications which these babies can have, and how to manage such patients antenatally as well as postnatally. WHO has classified babies on the basis of gestation, and a premature baby is a baby who is born before 37 weeks of gestation. And similarly, a preterm baby can be further subdivided into extreme premature baby, that is, babies who are born at less than 28 weeks, very preterm baby who is born at less than 32 weeks, moderate preterm are babies who are born between 32 to 34 weeks, and late preterm we call when a baby is born between 34 to less than 37 weeks. Now, this classification is important because as the gestation decreases, the risk of mortality as well as morbidity increases. Similarly, based on the weight, we have extremely low birth weight babies, that is babies who are weighing less than 1,000 grams, very low birth weight babies, that is babies who are less than 1.5 kgs. And similarly, we all know that low birth weight baby is a baby who weighs less than 2.5 kgs at birth. Now, we all know that prematurity, one of the leading causes of neonatal mortality in India and developing world. And this is something which is increasing because of the increased use of assisted reproductive techniques, more and more infertility, and this is going to be, the burden is going to increase further in times to come. Now, prematurity not only leads to increased mortality, the babies who survive also have an increased risk of impaired neurodevelopmental outcomes such as increased risk of cerebral palsy, visual impairment, and abnormal cognition, and they can also have hearing impairment. Now, since when a baby is born premature, all the organs are in developing stage. That is, they have not fully developed and have to undergo certain stages of development. So almost every organ bears a burnt when a baby is born premature. The most common organs involved include the central nervous system because of the incomplete myelination and other issues. The babies can have recurrent apneas because of the fragile vessels and impaired autoregulation. They can have bleeding into the brain. Because of the ischemia of the brain or because of the infection, inflammation, they can have periventricular leukomalacia. Similarly, they can have retinopathy of prematurity because of the abnormal vasculature of the eye, because of the opening of the fetal circulation, or because of the persistence of the fetal circulation. They can have shock, they can have open ductus arteriosus, which can cause various complications in itself. Similarly, in the lung, because of the lack of surfactant, they can have abnormal or decreased FRC leading to respiratory distress syndrome. They can have respiratory distress due to other causes like polycythemia, transient acute of newborn, and these babies can often remain on oxygen for prolonged periods of time and leads to a chronic lung disease, which we are well abreast with, and something which we call as bronchopulmonary dysplasia. Similarly, they have issues with tolerating the feed because of the immaturity of the gut, decreased peristalsis, lack of digestive enzymes. They can have feed intolerance. They can have inflammation of the bowel, leading to an inflammatory cascade, which we know as necrotizing enterocolitis. Similarly, metabolic wise, they can have, because of the impaired stores, they can have hypocalcemia, hypoglycemia. They can have increased risk of jaundice, osteopenia of prematurity. Besides other things, because of the immature immune system, they can have sepsis, which may be either transmitted through the mother, that is early onset sepsis, or nosocomial through the hands of the caregiver, leading to late onset sepsis. As these babies have low fat and large surface area, they can also land up in hypothermia, which itself can lead to various other complications. As we have already discussed that although majority of the complications happen in the immediate period, that is in the first 1 month of life, but even if the babies survive, they have to be under constant follow-up to assess their neurodevelopmental outcomes, and they can have problems with emotional and conduct like anxiety, depression. They can have difficulties in attention. They can have poor interaction. They can be hyperactive. They can have disorders like autism and other illnesses. And it varies from 30 to 50% depending on how premature a baby is. Now, the best thing whenever we are expecting a mother to deliver a baby preterm is intrauterine transfer to a center which has got level 3 NICU and is catering to such premature babies. And antenatal steroids, either dexamethasone or betamethasone, should be initiated for any mother whom we are expecting to deliver before 34 weeks of gestation to decrease antenatal complications by 30 to 50%. Magnesium sulfate is another drug which is very important to decrease neurodevelopmental impairment and decrease the risk of cerebral palsy. Usually, it is given for mothers who are expected to deliver babies less than 32 weeks of gestation. Similarly, if there are any overt infections like UTI or other infections, they should be treated properly with adequate antibiotic coverage. Now, why we stressed on the in utero transfer is because mother is the best incubator and the best ambulance to transfer safely the baby to higher center. It is not only cost effective, but it also decreases the perinatal mortality by almost 20%. It also decreases the risk of brain injury by with an odds ratio of 2.3, and the number needed to benefit is around 8. Now, in our part of the world, we usually give dexamethasone. That is 6 milligram, 4 doses, 12 hours apart for any mother who is about to deliver less than 35 weeks of gestation. It decreases perinatal death, neonatal death, respiratory distress syndrome, IVH, and it also causes reduced incidence of developmental delay during childhood. Antenatal magnesium sulfate, as we have already discussed, it does not have any major complications for the mother, but it does decrease the risk of cerebral palsy, gross motor dysfunction, and decreases the risk of death or cerebral palsy in children who receive magnesium sulfate. Now, postnatal intervention is very important. As we discussed, the labor room temperature or the OT temperature is very important. Each degree fall in temperature below 36.5 increases the mortality by almost 10%. These babies, because of the lack of the brown fat, large surface area, lack of subcutaneous fat, they are at increased risk of hypothermia, and hypothermia in itself can lead to increased risk of infection, hypoglycemia, metabolic acidosis, and respiratory distress. So it is very important to maintain a warm chain. The delivery room temperature should be 25 to 26 degrees Celsius. We should use warm humidified gases for resuscitation. Babies who are less than 35 weeks, we usually use a cling wrap or a polythene wrapping to decrease the evaporative losses and the heat loss. Skin to skin is preferred for more mature babies. We initiate breastfeeding in the delivery room itself if the baby is stable and is more than 1.5 kgs. Bathing is usually postponed, especially in the winters, and we usually carry a cap and a clothing to the delivery room. And as soon as the baby is delivered, we put a cap across the head and we use a cling wrap. And similarly, then when we have to transport these babies to an ICU, we use a transport incubator, which is in which we maintain the temperature about 25 to 26 and is using adequate humidification. Now, for premature babies, once they reach the NICUs, we maintain this warm chain with early skin-to-skin contact, and we encourage all family members, not only the mother, but other family members to initiate skin-to-skin contact as soon as possible and as long as possible. And we continue this KMC in our step-down wards, and we encourage the family and the other members, including our nursing staff, to give KMC and to encourage parents to continue it even at home. It has got rich dividends. It is not only beneficial to the mother, but also beneficial to the baby and the society. It increases the bonding between the parents. It reduces the stress in the mother, decreases hypothermia, hypoglycemia, increases milk production in the mother. There's decreased risk of infection. It also stabilizes the breathing and decreases the risk of apnea. Another important intervention is using a delivery room CPAP for babies who have respiratory distress. And we usually carry a TP resuscitator for delivering these babies. AMBU should be avoided for such babies because they deliver unregulated pressures to the babies, which can be harmful to these delicate babies. For similarly, for any mother who is having TPROM, we should initiate antibiotics early, especially for babies who are less than 32 weeks of gestation. And usually the common bugs which we found in our country is gram-negative sepsis like E. coli and Klebsiella. And usually we should not delay use of antibiotics in such babies because the odds of death and mortality increase with the delay in antibiotics in such premature babies. Now, other important thing which is in conjugation with CPAP is use of early surfactant. We should use surfactant if indicated within the first 2 hours of life to get the best benefits. And usually, any baby who's on CPAP of 6 and their FITO is more than 30%, and the cause of RD, respiratory distress is underlying RDS, we should give surfactant within 2 hours of birth. That is early rescue surfactant. And repeat dose can be given after 6 to 12 hours, depending on which preparation we are using. If there is persistent increase in FITO requirement, baby gets intubated, or there is persistent increased risk of increased work of breathing, or baby continues to have high FITO requirement, then we should repeat a dose. Other important thing is the use of caffeine in premature babies who are less than 32 weeks, preferably within 72 hours, especially if they require oxygen. We give a loading dose followed by the maintenance dose. It not only improves the respiratory drive, it decreases the risk of PPD and improves neurodevelopment outcome. Similarly, nutrition is as important as oxygen or inotropes. We usually start parental nutrition on day 1 with amino acids, lipids, GR of 4 to 6. And similarly, depending on how premature a baby is, we can start electrolytes on day 2 or day 3. Trophic feeds are encouraged, especially the colostrum, as soon as we get it from the mother. And irrespective of how premature the baby is, colostrum is always given within the first 12 hours in our unit. Fluids are given as per the gestation, and this is the protocol which we follow in our unit. There may be unit to unit variations. But after starting the fluid, you should always assess the weight of the baby, the fluid status, urine specific gravity, serum electrolytes to decide whether you need to increase or you need to come down on the fluids. Similarly, it is very important to nurse such small babies in incubators because that provides additional humidity to decrease the insensible water loss, which can be very high, leading to severe dehydration and metabolic acidosis. Now, for babies who are less than 28 weeks, we give them TPN between 28 to 30 weeks. We may start on full feeds on day 1 if the baby is stable through orogastric tubes. As soon as the baby crosses 31 weeks, we assess his oromotor maturation, sucking swallow reflex, and we start them on OG. We shift them to pallida or spoon feeds and encourage non-nutritive sucking. And somewhere around 34 weeks, we try for the breastfeeding, or when the weight is more than 1.8 kgs, we encourage the mother to breastfeed their babies. And remember that CPAP, ventilation, or central lines or umbilical lines is not a contraindication for feeding. Probiotics is something which are used across the globe, but there are some controversies. Many units use it for babies less than 32 weeks to decrease the risk of NEC, and it is used till 6 weeks or till discharge, whichever is early. It decreases the risk of NEC. Usually, we do not use it in our unit because the incidence of NEC in our unit is less than 1%, and so we do not use it as routine. Studies have shown that with the use of probiotics, the NEC decreases by 40 to 50%. It also decreases the mortality and reduces late onset sepsis. However, there are controversies in use of probiotics for ELBW babies or for extreme premature babies. Now, the other important thing, which is the major cause of concern in small babies, is infection. So, asepsis should be the main goal of the team who are nursing these babies in the ICU. Meticulous hand wash, hand up should be a norm. Use as much as possible the mother's milk because it decreases the risk of infection and does not cause NEC. Always prefer using disposables. You should always have an antibiotic stewardship and antibiotic policy for use in your units. And similarly, you should always have audit regarding the cultures and your first line, second line, third line antibiotics should be uniform and should not vary from unit to unit or from consultant to consultant. Similarly, we should follow other bundles of care like WAB bundle, CLAPSI bundle, and use of checklist is encouraged to decrease the risk of sepsis. It's always important to lay emphasis on prevention rather than using tons of antibiotics later to cure the infection in such babies. Skin is one of the important organs which is often ignored, and it is breach of skin which can be a cause of life-threatening sepsis. So always maintain the integrity of the skin. Use incubators to nurse these babies. Avoid putting large tapes. Use skin-friendly tapes like silicone tapes. Use oil massages. We usually prefer coconut oil in our unit. Prefer using barrier creams whenever you are putting a plaster to fix a tube or a line. And always change postures for sick babies because it again can lead to skin ulceration and breach in the integrity of the skin. Now, all babies who are nursed in NICUs or all premature babies, they are at risk of impaired neural outcome. So ensure that you give them an atmosphere which is resembling like a womb. So avoid excessive noise, bedside discussions, give them adequate time to sleep. We usually dim the lights from 12 to 6 in the morning. We do not disturb the baby. There should be at least 5 to 6 reasons for touching or disturbing a baby. Ensure skin to skin care as early as possible and be as gentle as possible to these babies because they are very fragile and the pain sensation is very high compared to the children and adults. We always prefer non-invasive investigations like daily check. We always prefer non-invasive ventilation over the invasive ventilation. We always prefer swaddling, nesting, or mother's milk before doing any procedure with the baby, like putting an OG, doing a vaccination, or taking the sample, or for that matter, doing an ROP screening. Before discharging such babies, you should have some checklists. Always encourage that you have at least one ultrasound at day 7 to see for the IVH and PVL for babies who are less than 34 weeks. For all babies who are less than 35 weeks, we have retinopathy premature checkup at 28 days of life. For babies who are less than 28 weeks or less than 1.2 kgs, we have the first checkup at around 3 weeks. We usually do the osteoprematurity screen with phosphorus, alkaline phosphatase, calcium at 2 to 3 weeks of postnatal age. And similarly, we start screening them for jaundice at 12 to 24 hours of life. And before discharge, we screen them for the common metabolic disorders, including hypothyroidism with TSH and free T4. Beyond 34 weeks, we check these babies for hearing with the help of OE and AABR and red reflex in the OPD. In summary, nursing a premature baby is like growing a plant from a seed. You should give an adequate soil in form of good in utero care and antenatal checkups. Mother nutrition or the adolescent girl nutrition should be an important factor in deciding the outcomes of such babies. You should have proper thermoregulation, that is, these babies should be maintained in a warm chain and they should, majority of their weight is because of the fluids. So fluids and electrolytes is an important part of management in such babies, especially in the first 2 to 3 weeks of life. And you should ensure early TPN, aggressive TPN on day 1 of life. And as soon as they become stable, start enteral feeding and at least give colostrum in the first initial hours of life. And always protects these babies from asepsis with meticulous hand wash, using disposables, using bundles, and avoiding unnecessary procedures, unnecessary lines and tubes. Thank you. I will be happy to answer your queries or questions if you have any. And thank you for the patient listening.